Welcome, welcome. All right. So I kind of already gave a little teaser to it, but now we're at the top of the hour. So let me just, as we're all gathered here today together as a learning community around crisis care, welcome to everybody. And today's topic that we're going to talk about in just a few minutes is going to be about caring for crisis staff, our workforce. A really important but challenging thing that we all are trying to address. So as I mentioned earlier, and I'm glad so many of you new folks are introducing yourself in the chat, we have over 75 organizations who are part of this learning community. If you don't see your name on there, let us know in the chat or email Karen. Also, remember that if you miss a week, and I have to admit that I missed the last couple of weeks because I was traveling, but no problem, because you can easily go to the Crisis Jam and you can see all of our YouTube videos of all past sessions and catch up. Or if you've seen something and you're like, I want to hear that one more time, or I want to share it with a colleague, go right over to Crisis Jam website. It's all there. So as you can see, our special youth edition is still at the top with over 1,000 views. And as you'll see, look at those numbers on Zoom. Some of them are really competing with the live. Some of these have more on Zoom than on the live. So that means some of us are revisiting or sharing as we've joined later in the learning community. So great work. All right, we have this up every week, but just in case it's fallen off your calendar, you know we're here every Wednesday. So you're like, why isn't it on my calendar? Why do I have all this space on Wednesday morning? Don't worry, you can revisit and download it, import the event file into your calendar. Also, if you're like, oh my gosh, I don't have time to figure out how to redo it on my calendar, I got to join, it's right now. No problem. Just go to the website, and over there on the top left is the Zoom link for that day. So you're never without us, okay? It's easy to find, and you can always look to see what's coming up soon. Remember, you can always scroll down, revisit some of the key things that we talked about last week, and there's always a little tidbit in there if you're looking closely about what's going to happen this week. So feel free to join us at crisisnow.com and catch up on things. A few news things this week that we want to point out. Here is an AFSP meeting that's going on actually today, starting right after this meeting. And some of the people who you're going to hear from today are also presenting at that. So we're looking forward to that. Really important suicide safer care in clinical practice. Looking forward to that. Now, this was kind of a pretty heavy thing that happened this week, and probably some of you saw this article. But just wanted to let you know that this is an individual who died behind bars at a state facility. They've done an investigation, and at least 10 people have been charged so far in that death. And we'll be following this for a while, but just in case you wanted to look it up, just came out yesterday, but really important and really speaks to some of the challenges we have when someone's in crisis, and how do we handle it in a way that's actually effective and doesn't further hurt the individual. On a lighter note, I don't know if you saw, but Ted Lasso and crew was at the White House this week talking about how important it is that we all realize that mental health is all of us. It is the commonality. So let me play a little bit about this when they were on stage at the White House.
In U.S. are focused on March Madness or the World Baseball Classic. Go Team USA tomorrow night, by the way.
Health. So like no matter who you are, no matter where you live, no matter who you voted for, we all probably, I assume, we all know someone who has, or have been that someone ourselves actually, that's struggled, that's felt isolated, that's felt anxious, that has felt alone, right? And it's actually one of the many things that believe it or not, that we all have in common as human beings, right? And so,
Wonderful. So our quote this week is both an important quote, but also a little preview for next week. So UCARA is a restraint-free training program to manage aggressive behavior that teaches us to reframe that behavior as a survival skill that guests have learned over time. And our job with crisis teams is to end the escalation. And that was from Matthew Hotzclaw, but we're having someone from UCARA, Kim Sanders, come speak about this program next week. So I think that's going to be really important and really reflects on some of the news articles that I just pointed out to you. So now I have the deep pleasure of introducing Becky Stoll, who's the Senior Vice President of Crisis Services at Centerstone. Welcome, Becky. I think we're all looking forward to your talk today.
Awesome. Thank you, Amy. So good morning, everybody. Coming to you from Nashville, Tennessee, where as you can see, it's kind of dark and dreary a little bit today, but hope it's nicer in your part of the world. So I know we talk a lot about, staff wellness and taking care of our staff and things like that. And I really want to hit for the next 15 minutes on some of the things that really are top of mind for me and for us at Centerstone right now around how we're going to continue to take care of people that work in mental health, but work in this slither of mental health that is crisis services. It's a much tougher job, as you all know. And I was fortunate in that somebody that worked for me for a really long time returned home to Memphis, Tennessee, and took a job as the mental health clinician for St. Jude's. And so when we were thinking about how we're going to tackle this and really take care of crisis service workers, I called her and said, how in the world do you get up every day and go to work and be a pediatric oncology nurse, physician, tech, and really got some good insight from her. And took some time to think about how that could translate into the work we do. So next slide, please. So the first thing out of the gate, and I don't know that we often think about it from this angle, we're so staff focused, but I really challenge all 228 of us that are on this call right now, and for the hundreds of you that are going to go back and watch this later, are we the problem? Do we have systems of care that are crappy, and we're trying to get our staffs to be well, given that they work in systems that are not great? And so I do think this is the genesis of this work. And if you're going to take this on, I really challenge you to look inward first. You can go to the next slide. Where we're taking a real look and doing this kind of detective work and seeing, do we understand what the issues in our own house are, and make sure that we're not asking our staff to be well in systems of care that on the worker side are not very good. So some of that takes getting your own house together. And how do we do that? What are the very specific issues that a program or a position face? And when, we really kind of peel back that and be honest and candid with ourselves and not assume, gosh, I did that job back in the day, I know exactly how it goes, to understand that for a lot of us, a lot of us that are in leadership positions, that was a really long time ago. When I did boots on the ground work, there was no email, there was no internet, there was no cell phones. I mean, it was a long time ago that I did that. So for me to assume that I understand the stress and the nuances of being a crisis call center worker, of dispatching on a mobile team, of working in a psychiatric walk-in center, or working in a crisis stabilization unit. Yeah, pagers. I used to have to carry a roll of quarters with me to the mall. I mean, that's another thing. Malls have kind of gone away too. So turn the lens inward first and see if you need to get your own house in order. And I say, don't be like this. We can be better than this. And what you hear oftentimes is the number one complaints from staff are in this bucket, that we are out of touch, that when it comes to what the reality of our staff workday is, that we don't really understand that. and we don't understand all the nuances of everything that they're out there doing on a day-to-day basis, and the workflows and things like that. So that sometimes when we implement things or say things, it really does come across as tone deaf. And so I really encourage you to parcel this out per program, and look at specific positions in the specific crisis continuum buckets. Don't just assume that all the crisis programs are the same, and what it's like for a call center person is the same as it is for a crisis stabilization staff. And even in those, the positions might be different. You know, in a crisis call center, you have staff taking calls, but you also have staff who might be doing just chats and text, or staff that do all three. And we need to be sensitive to that. And so before I think we start deciding what we're going to do for the staff and how we're going to help them, we do have to take this pause and really do a good analysis and a lay of the land, and make sure we understand truly by position and by program what are the struggles and the stresses that our staff are facing each and every day. You can go to the next slide. So then what do we do about it? There's so much talk and so much going on right now around staff wellness and how to take care of staff, and we can throw all these things at it. But there are, I think, some very minute things that we can do, and I just want to cycle through these and make sure that we're paying attention to all of them and doing things that can be helpful to the staff once they are working in a system of care that's healthy for them and well, and is not some work that we had to do to make it that way. So I remember when 9/11 occurred back in early 2000, and I was interviewed, like I'm sure everyone on this call was interviewed by media about what people could do. And this was like right after, I mean, this might have been like the day after 9/11. And I spoke with the reporter for quite some time and talked about a lot of different things. And they asked me questions. And the 30-second clip they played of me on the news was what could be helpful for people was to drink water and exercise. And I was mad and embarrassed. I mean, it was just like, really, that's the 30-second clip you took out. I tell you that story because I think we have to be cautious about that too, because we kind of just have all these things we tell the staff, do this, that, exercise and do all the, have good life balance and all that stuff. But we really, it has to go beyond that. And this really has to have more teeth into it. So the first thing, looking at HR and wellness departments and really seeing what you can do. What kind of information can you push out? What are the avenues you can push out about wellness? How can you message that mental health wellness is a priority for the organization? I know some places do like Wellness Wednesdays, and they provide information on physical, emotional wellness. And so work with those vehicles within your organization that can partner with us around maintaining good wellness. One of the things they heard loud and clear at St. Jude's was, don't have all the assistants be where the staff have to go get it and search for it. Take assistance to them. So in our crisis continuum, we need to take whatever wellness things we can wrap around individuals. Let's take it to them. And not force them to have to go dig for it or look for it. Take things, provide things to them is a really good one. If you're in a physical space and you don't have virtual operations, but for like mobile teams or crisis stabilization units, really some kind of space in the location where the staff can have their own downtime and their own quiet time so that they, can catch their breath and maybe do what they need to do. I'm building a crisis stabilization unit in North Tennessee right now in the northern part, and we're looking at a good space for the staff that's just dedicated for them. And then can you get creative. At St. Jude's, they had massage therapists who volunteered their time to come and do massages for the staff on site. The last time I had talked to my colleague, they had just bought a golden retriever for the staff to come in and love on a golden retriever. Sometimes it's helpful to have routine time where it's a staff only meeting so the staff can vent and talk about how rough the job might be. And then we need to be there for them in times of crisis so that the staff understand and expect if you have a bad call, if we have a violent incident, if we have these things, that we're there for them and there is a time set aside to debrief. And then really paying good attention to the onboarding process and making sure not only do the staff feel prepared to do the job that we're asking them to do, but that they also understand that we, you, us, all of us are going to take their wellness as a high priority because of the nature of crisis work, and that we're going to do this in a very methodical way, and that we do take it seriously, and that they are going to be provided things that are not going to burn them out, and that we have their wellness as top of mind. So that kind of ongoing encouragement just is paramount. So you want to start this from the second people come into the organization, and then just have this loop of wellness that is there constantly, all the while making sure the larger system in which you're asking your staff to operate in is functioning at just the best ways that it can. You can go the next. Lastly, when employees do need additional assistance, I'm sure, just like we have at Centerstone, and I'm fairly confident at all of your organizations, we do have employee assistance programs. It shouldn't be what we just immediately jump to. And if anybody's having, if the staff are all stressed out, that we're saying, well, just call the EAP. If EAP is warranted, I implore you all and challenge you to help our staff when it's time for an EAP referral. I often think we don't do a good job with this as an industry because we say, oh, hey, you can go to the EAP. But if people aren't feeling well, we probably should assist them with that if they need it. And we should ask them and have, I think, more conversation around EAP. I always feel like the EAP conversation is, well, we have an EAP and here's the number and you can call them. How about we ask people if they need assistance in locating a provider? We let them know how to access EAP, and if they don't know how to vet the list that there is or the people that they could go see, that maybe we could assist them with this. I've gotten lots and lots over the years of individuals who are saying, I called EAP and they sent me a single space list and it's like 8 pages long of clinicians. And I don't have a clue about how to pick one of these professionals, especially if it's staff that have not had to do that before. So, do they want somebody that's male versus female? Does it matter if you think a really good clinician is across town? Do they need to be more local? So let's help them in this way and provide them some of the tools they need. I'm seeing some of the questions in the chat, and I would answer them about, yes, we have to pay people a competitive wage, and I would comment on that. And there are special nuances. My call center is 100% virtual. My Tennessee, Indiana, Illinois, Florida-based call center is all virtual, and our 988 backup is virtual. So I am glad to talk to whoever that was that spoke about that. But I think we're going to spend a little bit of time with a couple of individuals who are going to come on and join in this conversation about taking care of our staff because we can do better. And this is a hard job. It's a hard field, and we have to do right by our folks.
Becky, thank you so much. And you're right that a couple folks have a few questions, but not too many. I think people were really kind of engaged with what you were saying. And there's definitely, I think, it resonates with us, right? That we need to do better. And I love the fact that you said we need to bring it to them, not just make it available on the website or the intranet or something like that. So I want to ask Jessica Reed to come forward and Adam Graham. And Jessica Reed is really going to, she's an implementation science specialist from Centerstone and really going to help us understand, how do you make it work in real life, right? It's great in theory, but how do you kind of make it work? And then we also have Adam Graham here, who's a clinical consultant from TBD Solutions, who's also going to reflect on workforce wellness. So Jessica, I'll hand it over to you.
Thank you, Amy, and thanks, Becky, for that great presentation and for really putting this focus on our staff and their wellness. That is such an important topic for us to focus on. So I'm going to tell you a little bit about how at Centerstone, how are we going about understanding the needs of staff related to workforce wellness? So we're really fortunate to have a grant from HRSA that's focused on culture change and building resilience in our workforce. But one of the biggest activities we're doing is creating leadership all the way down to staff feedback loops. And it's such an important piece to the system of being able to navigate and to go all the way from top levels of our systems and even outside of organizations into policymakers, all the way down to service delivery staff and frontline staff, to be able to share messages, share information, but also be able to feed back up into the system that feedback that's coming from them. And so in this example, we're going to staff and asking them, what does thriving look like versus surviving in your day-to-day work? And taking that information, sharing it with leaders, and then going back down the system again to say, these are the questions we still have. We're hearing, EMR is a struggle, the documentation and time for documentation is a struggle on top of everything else. But when we're going back down in those feedback loops and asking those questions, rather than saying, well, I can't do anything about our EMR and just kind of calling it a day, digging deeper, get to the root cause of what is it about the EMR? What is it about documentation time that really is a struggle right now? Ask staff to help identify some really concrete and actionable strategies for change. And those things might not be what you expect. But when we're facing challenges like workforce wellness, these things are so big that they can't be addressed from the top down by leaders. And so what we need are really these loops that go from the top down and then all the way back up again so that we can start putting some strategies into place that are really going to impact staff based on their experiences.
Adam?
Yeah. Hello, everyone. It is a privilege to join you all, and I so appreciate this intentional approach of dialoguing around staff wellness. I come out of 15 years of community mental health, most of that in crisis services before getting to be in this role as a clinical consultant, where I have the opportunity to talk with a lot of crisis centers around the country. And what I most appreciate about what Becky was saying is this shift that needs to happen from this external, like, hey, let's just plug and play. Let's find a couple things we can throw, $5,000 at and bring in this external thing. We'll tell folks about it and boom, that's staff wellness. But instead needs to be this internal look of when we talk about staff wellness, what we're actually talking about is the health of the agency. How are we operating as a full organization? And in my conversation so far, it really comes down to three really central things. It's money, mission, and management. That money, the idea of a competitive wage, of it's the same thing that we want in the works that we do, and that if we keep taking the same approach as you always have, and if as other groups are, like, you can expect to keep getting the same things. And I think there's some really innovative work out there of some folks choosing this difficult stance of saying our leadership is going to match pay, or is not going to increase pay until we bring up these other direct care positions. And I've seen that with a couple agencies and brought about, it changed workforce wellness, it changed the agency. On the mission side, it's a lot to what Jessica was just speaking to, that administrative overburden, that when I got into this work to care for people, and now it feels like the majority of my work is filling out documentation, that a critical look at what can go, like what has to be done by this clinician, and what can we either automate or move to other positions, so that there is this clear connection to mission. This is what drives people. Like, people will go through really hard things to be tuned in and in the work of that mission. And then management. And like Becky said, from that research, number one thing, we see this all the time, is that supervisors play such a key part. And that with good, healthy, tuned in, caring, supportive leadership, they can lead their teams through really, really difficult times. And when a leader is not tuned in, is not caring, is not supportive, is not out in front leading the way, that it can decimate a team really quickly. So I see those really at the central, and if we can stay not just intentional, but innovative when it comes to money, mission, and management, I think we can really move the needle in a way that supports our teams, and then enables them to support those who need us in times of crisis. So thank you guys so much for your time again.
Adam, Jessica, thank you so much to really bring it home how we could really do it. And I do like this idea of money, mission, and management, and also this idea of thriving, not surviving, which I've heard before, but today, I think in the context of thinking about our care for ourselves and then also our care for our teams. And I liked that idea of, are we the problem or the solution? And looking inward first, which is kind of what you're talking about also, Adam, I think is a really powerful, but definitely hard thing for us to do, right? So really appreciate that, and appreciate Becky for kicking this off, this conversation. And I know that this is a conversation that's an ongoing thing on the JAM, is really how to take care of our workforce in these extremely stressful jobs. So thanks all three of you for joining us today on the JAM. We will move forward. I just want to remind you again, in case you weren't here a few minutes early, remember that SAMHSA has a full complement of assets around crisis services. A slice in Spanish, a bunch in English. There's over 300 items. If you like to shop, this is a good place for you to shop and bring back some things to your clinic. I think it's a great idea. And remember also, if you don't have your JAM shirt, well, you're kind of not in the cool club. And so I'm not wearing mine today, but I do have a couple. And so really encourage you to pick up your 988 shirt. It's just a good way for us to keep the marketing going, keep people to know about 988, and really just normalize the use of 988 for individuals. All right, so let's move on to the hot seat, my favorite parts. And let's bring forward Caitlin Davidson. Hope you're here. Hi, Caitlin. Good to see you from Vibrant. So happy to see you. So you're ready for some hot seat action?
I sure am.
Okay, great. So here we go. The last piece of legislation ever signed by JFK was the Community Mental Health Act of 1963. Okay, a long time ago. It envisioned a meaningful life in, quote, the open warmth of community, unquote, for individuals with serious mental illness and developmental disabilities. Now, there were 5 key pillars of this piece of legislation in 1963. Which of the following was not one of the 5 key pillars of the Community Mental Health Act? Was it outpatient clinics, inpatient clinics, emergency response, or all 3 of those were included? Now, Caitlin, we'll all everybody put in your answer. We'll give Caitlin a little support here. Let's see what we've got. Are you feeling strong about any of the answers?
So I have a little bit of an inkling towards B not being included, but I'm gonna wait to see what the audience says.
And that one would kind of make sense, right? It was a period when we were moving into community care. So I understand that not being included. Let's see what our audience members have to say, how they'll help us. Oh, really mixed. So most people said that they felt like emergency response was not included, but your inpatient one still got a quarter, 20% of the vote-ish. And some people thought, oh, all of those were in there. So do you want to ask a friend? Do you want to make your best guess? What would you like to do?
All right, so my second guess was D, and since that
Okay.
has more votes, I'm going to go ahead and say D.
Okay, final answer. She's going with D. All three were included. Let's reveal. Woohoo! You earned your shirt.
Trust the audience.
Yeah, just not only being on here, but you actually got it right. So what's kind of interesting about this and why we've also highlighted the green is it's kind of interesting that all the way back then, they were also seeing emergency response as an important pillar. And we haven't done a lot in that area until now, you know, in terms of, I mean, we've done a lot, but hasn't been at the forefront until now. So you were right. It's awesome. Thank you, audience, who was, of course, as always, the brain trust of the learning community, always knows what's right. And it's interesting to think about the fact that they even thought of emergency response that far back. So Caitlin, thank you for joining us. You'll get your swag. Appreciate you being here today. All right. So we want to move on to the SAMHSA update. And Richard McKeon, are you here?
I am here, Amy.
Wonderful. We'd love to hear your SAMHSA update.
Okay, great. Thank you very much. So I will mention a couple of things. I will try to be quick. But one is that I'll take this opportunity because I've gotten a number of questions from people about my change in role and what it meant. So let me just clarify for anyone. So I, as many of you know, have been for over the past decade, the Suicide Prevention Branch Chief in the Center for Mental Health Services. I have recently been detailed to the 988 in Crisis Office as a senior policy advisor on suicide prevention. So anyway, that's what's happened. I'm not retired, not gone anywhere, and continue to be actively engaged in a wide range of issues with suicide prevention and crisis services. And one of the things I wanted to make sure that people were aware of, and for those of you who might have been engaged with the National Action Alliance meeting last week, you would have heard this because it was announced by our Assistant Secretary, Miriam Delphin-Rittman, as well as Terry Tanillian from the White House Domestic Policy Council. And that is that the White House has asked for a process to be started to, in 2024, release a revision of the National Strategy for Suicide Prevention and to incorporate into that an action plan. This is really important for those of you who may not be familiar. The first national strategy was released in 2001. It had nothing about hotlines or crisis services. The second was released in 2012, and a number of people were involved in that effort. And that did include some emphasis on hotlines, lifeline standards, and crisis services, but nothing like the emphasis that is taking place now. That 2012 strategy was released with the intent of it being the nation's strategy for the next 10 years. So we're actually now in year 11 of that. So that is part of the reason for revising it, to look at how to translate into a meaningful action, building on the Surgeon General's call to action to implement the national strategy for suicide prevention, to incorporate equity more strongly, and other things. 988 was not envisioned at all when we released the national strategy in 2012. So there'll be more to come on that, but wanted to make sure people on this call were aware that those are discussions going on and finalizing the process that will be used, how input will be obtained, et cetera. That work is going on currently. So we'll keep you all updated. Thank you. Looks like you're on mute, Amy.
I was going to say, everybody's always looking where you are, and I want to make sure that they still have you as a touch point. So thank you for the update on your detail, because people were worried that you were going somewhere, because you're such an important touch point on these. So I just for that. Are you here? Here, because I saw him.
Yeah, I'm here.
Wonderful. Welcome. Let us go to slide.
Yeah, we can go to the next slide. Hi, everybody. I'm happy to do sorry for the delay getting off mute. Happy to do the updates for NASHBID. I'm going to focus. I really liked what we were discussing before about workplace, and we really need to think about workplace across partnerships. So I want to focus on the report that was written, Lending Hands, as part of the compendium that NASHBID produced on behalf of SAMHSA over the summer, taking care of the workforce and police and at the police and behavioral health interface. We can go to the next slide. So in that paper, which hopefully you all have access to and have downloaded, recommendation number 4 was that there should be policies for multidisciplinary responses that should be built into the crisis delivery system, including those that address staff safety, public safety, and management and treatment of high-risk encounters that involve volatile individuals who may have means to harm themselves or others during the encounter, while taking into account constitutional rights, the ADA, case law, and federal statutes that may play a role in shaping practices. Next slide. Well, in light of that recommendation, I think it's important to highlight what we heard John Palmieri talk about, I believe it was last week, which was the March 8th release of the Department of Justice investigation of Louisville Metro Police Department and the Louisville Jefferson County Metro government, in which they looked at patterns and practices, including those that impacted people with disabilities. And there's a whole section of the report related to the Americans with Disabilities Act. So that lending hand papers really speaks to those partnerships and the key importance of paying attention to those constitutional issues. But as we do that, we have to think about these risk encounters. Next slide. And how do we take care of our workplace and workers who might be dealing with these? Well, first of all, we're going to see more about this in upcoming papers produced on behalf of SAMHSA, but we have to think about, role clarity. How do we nurture our staff and make sure that they know what their roles are so that they feel safe and comfortable in these complex situations? What are the systems and structures that should be put in place to make sure that the right hand and left hand are lending hands to each other, but knowing what they're doing? Are there policies and procedures that help direct staff so that they feel that they know what direction to go in, which can be a major stress reducer so that they're not trying to figure it out as they go? And then looking at liability considerations. A lot of times staff stress in these crisis spaces relate to, am I going to get in trouble if I do something wrong? And so we need to understand that a little bit more. And that's an evolving conversation. Cross-training is going to be key, really helping people get the tools that they need. We heard Amy Watson talk about last week that there hasn't really been a curriculum for all the people that we're sending out to crisis services. And so what do we do to build across a training? Injury prevention of the people we're responding to is obviously going to be important, as well as injury prevention for the responders. We know that there's data of injury towards EMS, injury towards law enforcement. Mobile crisis workers want to stay safe. We want to improve their wellness by helping them feel safe. So we have to think about injury prevention for all parties involved in a response. And then also trauma prevention. If we look at some of the data and what we saw during COVID, we saw EMS, law enforcement, and mobile responders really struggling with exposure to traumatic circumstances and their own wellness. And so I love today's talk, which was really to be intentional about taking care of everybody's wellness as we go forward and thinking about trauma prevention and what do we need to do to help the responders be able to go back out into the field and give their best in those responses. Next slide. So this is just, there's more to come on this, obviously in 3 minutes, we can't cover it all. You will see in this year's 2023 papers that will be revealed over the summer and fall, a paper on 988 911 interoperability that will talk a little bit about what communities are doing with that, how to access care, workforce issues, and lots more. So in our Beyond Bed series, there's more to say, and I just wanted to talk about that today in light of the earlier conversation. So thank you.
And I'll just jump in quickly, and if we can go to the next slide, this will be a quick federal appropriations update. So Joanna went through this slide last week on the President's FY24 budget request. Secretary Becerra has begun his tour of the Appropriations and Health Committees on the Hill this morning, actually, with the Senate Finance Committee testifying about this budget request and answering questions. This afternoon, he'll be in front of the Senate Appropriations, Labor and Health and Human Services Appropriations Subcommittee. And then next week, we'll continue on the House side with a few more visits. There was specific mention in his opening testimony of 988. And from what I've seen this morning, a few different questions on mental health. If there's anything particularly relevant for the JAM, we'll provide a link to the clip next week when we meet. But for now, I'm going to turn to Joanna to cover some of the proceedings in the House and for FY24 budget process.
Thank you, Sarah. So this week, House Appropriations Ranking Member DeLauro released some letters that she's received from agency heads that speak to potential results that possible budget cuts that we're hearing might be forthcoming in FY24 would have on specific programs and on these agencies if they were to go forward. For context, some House leadership are proposing cuts, cutting the FY24 discretionary spending back to the FY22 levels. And these letters detail the impacts that those cuts would have. I will drop the link to them in the chat momentarily, but Secretary Becerra sent one of these letters for HHS, which was released along with the rest of these letters, and outlines that a 22% reduction to the Lifeline funding would probably cut contact responses by 900,000 to approximately 3.3 million contacts. He estimates that nearly 1 million people who might be facing a suicidal or mental health or substance use crisis would be unable to access support and stabilization facilities or stabilization services if these cuts were to go forward. So obviously this is very concerning, especially given the progress that 988 has made and the increases in outreach we've seen over the last just 7 months since 988 came online. So we're going to be keeping an eye on that and hope that this can rally people to keep pushing for higher 988 funding and not cut us back. But thank you. That's all we have for today.
Wonderful. And you're right. It's so important that we are able to keep pushing because it's actually being used and we're getting quick responses to individuals. Behavioral health responses is so important. So hopefully that will move in the direction that we want. And we will answer you in the chat. Joanna, if you could answer in the chat, someone's asking, how can they advocate? And so thank you, Joshua, for asking that, because yes, the more voices, the better. So I'm going to turn it over to Stephanie Pasternak at NAMI.
Thanks, Amy. So yes, for an update on kind of 988 state implementation legislation, I'm going to start off with a couple states and then call on my colleague Caitlin to round us out with a North Dakota update. But I wanted to start with the state of Maryland. You might remember last session they created a 988 trust fund in legislation. That's a strategy we've seen 12 states take thus far, and those are special accounts in the state budget to organize and protect 988 funding. Currently, Maryland has another set of companion bills to add an additional $12 million into their state 988 trust fund over the next budget cycle. And happy to report that both versions of those bills have made it out of their original chambers and are being considered in their second chamber now. Also, you might remember, so this is not necessarily implementation legislation, but some states are also taking the strategy of studying their 988 systems. Where are their gaps, challenges, how can they maximize different funding streams? And Florida, this session is one of the states considering legislation to do just that. They have Senate Bill 914, which has passed out of committee earlier this week. And really what that would do if it makes it all the way through the process is require the state to study the adequacy of their current lifeline and associated crisis services, and then make financing recommendations to the legislature about how to best support 988. And with that, I will turn things over to Caitlin over at Vibrant to update us on the North Dakota bill.
Thanks so much, Stephanie. So as you may remember, we're still tracking North Dakota quite closely. Last week, the House Committee on Finance and Taxation amended Senate Bill 2149 to unfortunately strike the 988 fee and instead referred the bill to the Appropriations Committee, but it still includes $2 million in appropriation funding for the 988 Crisis Stabilization Fund. So we're watching this bill closely, and I know the House Appropriations Committee is scheduled to hear the bill tomorrow morning, so we'll provide an update next week. And that's all for me. Thank you.
Terrific. Stephanie, do you want to come back and talk to us just a little bit about this kind of line of the South that's all still gray? Anything to give us a little hope about that?
Yeah, maybe I should just provide a little bit of clarity too on the purpose of the map. So the map is specifically focused on state legislation that has occurred either slightly before 988 launched or thereafter. And so some of these states that you see in gray, you might be worried that nothing's happening there. But I will say across the board, we're really seeing states really look at their spending on their hotline, mobile crisis stabilization, and include increases for that. A lot of those states that are in the South there are creating new crisis stabilization centers, upping the funding for their 988 lifelines. And I will say, if you visit that link that's just above the map, you can see some of those kind of budgetary bills in a chart that lives underneath of our map there. That's great. That's reassuring because I felt worried about the gray area, and especially because it felt like it was the South. So it's great to hear, because we know Arizona and Georgia are some of our leading states for work in crisis. So we're kind of surprised, but thank you for the insights onto the map. All right. I have the pleasure now of turning it over to Stephanie Hepburn, who's going to talk to us about her recent interview with Dr. John Strauss. Stephanie?
Thanks, Amy. So I'd like to welcome Dr. John Strauss. He's the founder of the Massachusetts Child Psychiatry Access Program, MCPAP for short. Let me know, Dr. Strauss, if I'm getting that wrong.
No, that's right.
That's right. In Massachusetts, there are 36 child and adolescent psychiatrists per 100,000 children, and that makes it tough to get an appointment. However, a family can get a same-day appointment with a child's primary care physician. John, how does MCPAP help fill in the mental health care gap for young people?
Well, thank you, Stephanie. Most families do have their primary care clinician that's relatively close to their home and available, and is used to doing taking care, whether it's an ear and ache or whatever, taking care of you on the same day. So we wanted that same standard to apply to behavioral health, and but many of those primary clinicians were not very comfortable with the behavioral health problem. So what happens is you come in, if your nurse practitioner or physician or family doc is not comfortable, they can pick up the phone and talk immediately with a child psychiatrist and or a behavioral clinician, or even get help with referrals for services. But most of the time, it's helping the doc think through what is best for the family.
And one, I think listeners would really like to hear, how is this being paid for? You know, I've talked about how the legislature in 2016, I believe, right. What happened?
Well, in Massachusetts, it's paid for very different ways across the country. There are now, I should say, there are about 46 states that have a program in one form or another, and 4 territories and 2 Indian tribes. And But in Massachusetts, it's paid for by a surcharge on the insurers. So that this is really a health service. We're doing a consultation, and the health insurers have felt that this is something they should pay for. There's various different mechanisms to enact that. Washington State has a little different process, but also has the insurers paying, and there's pending legislation in Rhode Island and Maine to make it happen there.
And I believe in Massachusetts, it's just commercial insurers, but in some other states, they've pulled in Medicaid as well.
Yes, right. Yeah.
Well, thank you so much, Dr. Strauss, for hopping on the call with me.
Yeah, welcome. Glad to be here. And just to mention, if you want to find out your organization that's doing this work in your state, you can go on the National Network website at www.nncpap.org and get a picture of what's going on in your state.
And is that the same for the perinatal line as well? Or is that
No, the perinatal line is Lifeline for Moms, the Lifeline for with, and then moms.com.
Thank you, Dr. Strauss. I'll pass it back to you, Amy.
Wonderful, Dr. Strauss. Thank you so much for that. And you know what I think is so interesting is, and again, as we're talking more about implementation on this call and with our roundtable today, and also with Dr. Strauss about like, how do you pay for these things? How do you really make it happen? Of course, we'd love this, but how do you make it happen? And so appreciate him really highlighting how he got commercial insurers and Medicaid to pay for some of these really innovative ideas. So really appreciate that. And of course, also appreciate the equity between physical health and mental health, behavioral health. So appreciate the fact that he kind of said, listen, it should be the same. And so I love when I hear people who are doing that kind of work. So let's move on. One of my favorite people, Vic Armstrong, is going to be with us today for Tough Talk. Vic, I just have to say, most weeks when you present, I get a little choked up. So always appreciate your insights and you pushing us in the right direction. So welcome, Vic.
Thank you. Community can be defined by geography or relationship. You may define your community as friends, neighbors, co-workers, or cultural or ethnic groups, as well as the town where you reside. How you define community may impact your perception of how you are impacted by suicide. Often the narrative is that suicide affects other people, other communities. The reality is that suicide impacts all communities. My narrative growing up in the Black community was that people of color don't die by suicide, that it was not a problem for the Black community, that suicide was a white people's problem. That was a narrative handed down to me by my family and by my community. My narrative was that in my community, we are strong, we are resilient, and we survived slavery, therefore we can survive anything. I was told that we don't need therapy, we just need God. I was told if you're struggling, pray harder and have more faith. But do not talk about depression or anxiety, and what happens in this house stays in this house. My narrative was wrong because I was misinformed, and so was my community. The truth is that one of the fastest rising demographics for suicide is young Black Americans. Suicide is a community issue, however you define community. It is not a school issue or law enforcement issue or hospital issue. Suicide isn't limited to the young, the old, gay, or straight. It's not only an issue in the Black community, the white community, Latinx community, or the Asian community. It is an issue that impacts every community. It is a public health issue that will require a public response, a community response. It will require a response that considers that we not only need evidence-based and evidence-informed practices, but community-informed practices. It will require population-level interventions that focus on the root causes and contributing factors, including unresolved trauma, poverty, racism, and violence, all of which put people at higher risk of developing mental health issues. Suicide is a community issue, and it will take all of us working together to end this robber of life, and that is Strong Talk.
You never disappoint, Vic. Thank you so much. Really appreciate. All right. You know, one of the things I just keep hearing over and over today, and I mean, I've heard it on here before, but this idea of it's all of us. And, you know, the learning community is big, but, you know, the ripple, we have to keep talking to others and ensure that we're advocating for a continuation and good support for the 988 Lifeline and all the work that all of you on this call are doing. So if you haven't watched some of these Moving America's Soul shorts, you're missing out. There's just an amazing first person account in these. And this week we didn't have our first person corner, but it's a good time for me to remind you about these Moving America's Soul on suicide. They're just absolutely excellent. And I believe that I've heard that our last one is going to, episode 9 is going to be dropping soon. This is a woman who's a big Spartan competitor. And she attempted suicide early in her life. And so she tells her story, and this is going to be coming up in the next few days. But also, just a little plug here, National Council's annual meeting, RIA International Leadership, and several people from this movie series are going to be doing a talk there. And so really looking forward to that, to bring real stories forward, which are so impactful for our colleagues. All right, so what's coming up? Lots of good stuff, I will say. And as soon as the curtain opens, I will give you the details. So coming soon, Kim Sanders. Remember, I kind of told you at the top of the hour, the quote of the day was from UCARU. Kim Sanders is going to be coming next week. Really talking to us about a new way to manage crises de-escalation. And that's going to be really helpful for us. And she's really going to help us turn the way we think about these. And we've all dealt with it. So it's always good to have a good reminder. And then Cosette Ayel is coming to talk about community mobile response works. And that's really going to be reminding us again about the importance of non-police response. And we're all on board with that, but to hear her perspective is going to be really important. The other thing that's not on this page that's coming up I think this right after Cosette is going to be a week where we're going to have something on LGBTQ responses to crises. So that's going to be another good one. So there's just so much coming up that's going to be great that I hope you will join us as you did today. All right. Oh, the movie, where will it be able to be viewed? You can, if you Google, go back one slide. If you Google Moving America's Soul, it'll come right up and you'll be able to watch the shorts there. And yes, April 12th, Angela Weeks from the LGBTQ populations talking about 988. So lots of good stuff coming up. Can't wait to see you in the coming weeks and to chat with you in the chat. I don't think there's any more slides, are there? I'm so confused because we've got we went backwards. We've got these good folks coming in the next couple weeks. And then, right. So thank you again to the people who joined us today. Big thank you to Becky Stoll, Jessica Reed, Adam Graham, Caitlin Davidson, Dr. McKeon, Dr. Pinels, and all of our groups from the federal updates and state updates. And of course, our Tough Talk from Vic Armstrong, Dr. John Strauss for giving us some insights into child crisis care. Thank you all for being with us today, and I will see you next Wednesday.